welcome to the Radonc Smart Review GYN Cancer Series.
Hey everyone, so today we're really getting into the practical side of definitive cervical cancer brachytherapy.
Yeah, this is mandatory part of the cure for many patients, right?
Absolutely mandatory. And, the evidence is solid, but actually doing it, the technique, picking the right applicator, nailing those dose calculations, that's where things get really crucial for residents at all levels.
Exactly. We're moving past the epidemiology and staging today and getting hands-on, thinking about the sim suite, the procedure itself.
Our goal is to give you that systematic approach, the evidence behind why we choose certain things and really understand the radiobiology so you can make safe, effective plans.
We want you feeling confident, basically. Whether you're asked to describe the procedure on rounds or, calculate a cumulative dose constraint for boards.
Right. So let's frame this with a typical case. Let's think about Mrs. Jackson. She's 60 years old, diagnosed with stage 3 C1R cervical cancer.
Okay. And she's finished her external beam part.
Yep. Completed 45 gray pelvic chemoradiation, standard 25 fractions.
Good. And how did she respond?
Pretty well, actually. Significant tumor shrinkage. On her pre-brachy MRI, the residual high-risk clinical target volume, the HRC-TV, it's measuring around 25 cubic centimeters, so manageable.
Okay, 25 cc's. So that leads us to the key questions for today, right?
Exactly. 3 big ones, I think. First, what's the step-by-step way to do this safely? Like the polished description you need for, say, mock orals, your canned speech.
Good one.
Second, for Mrs. Jackson specifically, with that 25 cc volume, is a standard intracavitary applicator, tandem and ovoids, is that enough? Or does the evidence push us towards adding interstitial needles?
Critical decision point. And the third?
And third, the numbers game. What are those absolute dose limits, the cheat sheet for organs at risk, the OARs? And crucially, how do we actually calculate the cumulative EQD2 equivalent dose in 2 gray fractions to make sure we're staying within those limits?
All right. Sounds like a plan. Let's tackle the procedure first. That systematic description.
Yeah, let's start there.
For any resident, having that polished sort of automatic description of the tandem and ovoids procedure, it's just non-negotiable, isn't it?
Oh, absolutely. Whether it's your attending grilling you in the vault or an examiner staring you down during boards, you need that description to be smooth, accurate, systematic, shows you know what you're doing and that you prioritize safety.
Totally agree. It's like a safety checklist you've memorized. So could you walk us through it, like exactly how you'd present it in that formal setting?
Okay, I'll do the canned speech verbatim. Here we go. To perform the intracavitary brachytherapy, I would first ensure the patient is in the operating room or procedure suite, and I would induce monitored anesthesia care, or MAC, with an anesthesiologist present. The patient is carefully positioned in the dorsal lithotomy position. My first step upon positioning would be to insert a Foley catheter, primarily for drainage, but also to define the bladder for later contouring and dose assessment. Next, a speculum exam is performed to visualize the cervix and confirm access. I would then sound the uterus to determine its precise length and orientation. This step is crucial for preventing uterine perforation. We must use transabdominal or preferably transrectal ultrasound guidance while advancing the tandem to reduce the risk of uterine perforation, especially in cases of a retroflexed or mogul uterus, and to visually confirm that the tandem has reached fundal placement. Based on the sounded depth, the flange in the tandem is then meticulously set to approximately 0.5 centimeters shorter than the measured sounded depth. This small buffer prevents the tandem from impacting or perforating the fundus once the ovoids are applied and tightened. I would then insert the tandem into the uterus. Once the tandem is seated, I select the largest ovoids that fit comfortably and snugly in the vaginal fornices. We apply the ovoids and assemble the applicator, ensuring that the ovoids are level and symmetric relative to the tandem. We are looking for maximal dose delivery while respecting the vaginal mucosa limits. Finally, and this is a safety-critical step, I would pack the vaginal canal with gauze. This packing is done both anteriorly and posteriorly. The purpose of the packing is dual. First, to increase the distance from the applicator to the bladder and rectum, thereby reducing D to cc, and second, to mechanically stabilize and hold the entire applicator securely in place during imaging and treatment.
Okay, that's really clear and systematic. Perfect.
Yeah.
But let's, drill down on some of the nuances examiners love to pick at. You mentioned setting the flange 0.5 centimeters short. Why is that specific margin so vital? I feel like sometimes people just eyeball it.
Eyeballing that is asking for trouble.
Yeah.
That half centimeter is like the critical safety gap. See, when you sound, you get the absolute maximum depth, right?
Right.
But when you put the ovoids on and secure everything, you often put a bit of counter traction on the cervix. It can slightly shorten the effective uterine cavity length.
Okay, I see.
So if your tandem is set exactly to that sounded depth, that tiny shift could actually push the tip through the fundus. That half centimeter is your safety net against uterine perforation. It's absolutely non-negotiable. A perf sends the patient straight to the OR.
Got it. And about the guidance,
Yeah.
you mentioned transrectal ultrasound is often preferable to transabdominal. Why is that?
It really comes down to image quality and, well, proximity. Many of our GYN cancer patients, maybe they're obese, maybe they have surgical scar tissue. Transabdominal views can be pretty murky sometimes. It's hard to be certain where that tandem tip really is.
Okay.
Transrectal ultrasound, though, it gives you this high-resolution, really close-up view of the cervix, the path the tandem is taking, the fundus. You can see exactly where it is. Confirm placement without doubt. It just dramatically cuts the risk of perforation. It's a major safety boost.
Makes sense. Better visualization. Now, what about the packing? You really emphasize that for safety. Can you expand on the physics there, like displacing the OARs, and how do we judge if the packing is actually good?
Yeah, this is core brachyphysics, right?
Yeah.
81st square law dominates everything. Dose just plummets with distance.
Right.
So by pushing the rectum back posteriorly with gauze, even if it's just a few extra millimeters, those millimeters can mean a dose reduction of like 10, maybe even 20 gray EQD2 at that critical D2CC point. It's huge.
Wow, okay. So how do we check?
The key check is on the post-procedure CT. You look right at that interface, posterior vaginal wall, anterior rectal wall. You absolutely need to see a visible, low-density layer of gauze separating the applicator from the rectum.
And if you don't? If they're touching?
If there's direct contact or just a tiny sliver of space, that packing is insufficient. Your physicist is going to have a really tough time meeting that rectal constraint without compromising target coverage.
Got it. So procedure done, packing looks good, hopefully.
Mm-hmm.
Then we move to imaging verification. What are the absolute key checks on that post-procedure CT?
Okay, yeah, the CT scan is where you verify the geometry before any dose calculation starts. Super important. First is the tandem central. Is it sitting nicely in the midline of the uterus, or is it tilted off to one side?
Check 1, central tandem.
Check 2. Packing adequacy, we just talked about that. Look especially at the posterior packing displacing the rectum. Is there enough space?
Check 2, posterior packing.
Check 3, flange position. Is it snug up against the external os? That confirms it's seated correctly and hasn't slipped out.
Check 3, flange at OS.
And check 4, symmetry. Look at the tandem relative to the ovoids. Is it sitting symmetrically between them? This ensures your planned source positions are actually achievable.
Okay, central tandem, posterior packing, flange at O, symmetry. Got it. And then for the planners, the reconstruction steps in the treatment planning system are just as vital, right? It seems easy to just click through that.
Oh, absolutely critical. You can't gloss over this. First, make sure you've selected the correct applicator library model in the system. Every manufacturer's applicator is slightly different. Millimeters matter hugely here.
Right, use the right model.
Then, confirm the geometry matches the CT. Check the channel paths for the sources, the distances between source positions, the angles. Does it all look right?
Verify geometry.
And the final safety check before you even think about optimization. Are there any potential source path collisions? Could the source get stuck moving between points? If your geometry reconstruction is off, the whole dose calculation, the whole plan is fundamentally flawed from the start.
Okay, meticulous checks are key. Procedure, CT verification, reconstruction.
Exactly. Now that we've got the how-to down, let's talk about which applicator to use. This brings us right back to Mrs. Jackson.
Right. The standard tandem and ovoids is elegant, gives that nice pear-shaped dose distribution. Great for tumors that are mostly central.
Perfect for small central tumors.
Yeah.
But, like you said, cervical cancer isn't always neat and symmetrical. What if it's grown out sideways into the parametria, those soft tissues next to the cervix?
Yeah, then that pear shape, because of the rapid dose fall-off you mentioned, it might completely miss the edge of the tumor out laterally.
And that's exactly the problem interstitial needles are designed to fix. They let you extend that high-dose region outwards.
So how do we decide? Is it just physician judgment, or is there solid evidence?
Oh, there's very solid evidence now. This is a classic evidence-based decision point, and the answer really comes from the retroembrace analysis. Big, important study.
Okay, retroembrace. Let's drill into that. What did that analysis tell us definitively about tumor size and needing needles?
It gave us a clear quantitative threshold. Basically, they looked back at a huge number of patients and found that for those who had a large residual tumor volume at the time of brachytherapy,
Mhm.
specifically an HRCTV volume of 30 cubic centimeters or greater.
30 cc's.
Okay, for those patients, using a combined approach was essentially mandatory for best outcomes.
Combined, meaning the standard, tandem, and ovoids, but with interstitial needles added through a template.
Precisely. Those needles let you actively shape the dose, push it laterally to cover the parts of the tumor that ovoids just can't reach effectively, and the impact wasn't small.
What was the outcome difference?
It was a 10% higher local control rate at 3 years for the combined approach compared to intracavitary alone in those larger tumors.
Wow, 10% difference in local control. That's huge. That's not just a suggestion. That's basically a clinical mandate, isn't it?
It really is. A 10% LC difference is something we absolutely have to act on.
Okay, so 30 cc's is the magic number. Let's bring it back to our patient, Mrs. Jackson. Her residual HRCTV was 25 cc's.
Right, so based squarely on that retro embrace data, a standard tandem and ovoids applicator, assuming it's placed well and packed meticulously, is likely sufficient for her.
Because she's under the threshold.
Exactly, she's safely below that 30 cc mark. We should be able to get adequate coverage of her HRCTV without needing the extra complexity and potential morbidity of adding interstitial needles.
Okay, that makes sense for her. But let's flip the coin. What if her MRI had shown, say, 45 cubic centimeters residual, maybe significant extension out into the left parametrium?
Well, that is the decision point in action. If her volume was 45 cc's, especially with that lateral extension, then based on retro embrace, we must add interstitial needles.
No question about it.
No question. If we didn't, we'd essentially be accepting a 10% lower chance of cure for her. The needles become essential to boost the dose out laterally, conform that high dose to the larger asymmetric tumor shape. Making that call based on the 30 cc threshold is honestly one of the most high-yield, evidence-based decisions you make in GYN brachy.
Got it. 30 cc's. Need needles. Under 30. Probably okay with intracavitary alone if central. Clear. Okay, let's shift gears to the numbers, the dose constraints. This gets into the nitty-gritty.
Yet the quantitative side. Modern planning, as you know, follows GCStro and Embrace guidelines, and that means we report everything, all the cumulative doses using EQD2, equivalent dose in 2 gray fractions.
And this is where we absolutely had to dust off our radiobiology, right? Specifically, the alpha-beta ratios.
Critical. Got to use the right one. For the tumor targets, HRCTV, IRCTV, we're interested in acute effects, tumor kill, so we use an alpha-beta of 10.
Okay, alpha-beta 10 for tumor.
But for the normal tissues, the OARs, we're worried about late effects. Fibrosis, fistula, stenosis, those are driven by different mechanisms.
Yeah.
So for OARs, we must use an alpha-beta of 3. Using the wrong one, it completely messes up the EQD2 calculation.
Alpha-beta 3 for OARs. Got it. So let's talk targets first. What dose are we actually trying to achieve in the tumor to maximize cure?
Right, the goals. The main one is for the high-risk CTV, the HRCTV. We look at the dose covering at least 90% of that volume, and the goal here is pretty demanding. We need at least 85 to 90 gray EQD2.
85 to 90 gray EQD2 D90 to the HRCTV. That's the main driver.
That's the driver. If you fall short of that, local control rates really start to drop off. And then for the intermediate risk CTV, the IRCTV, which is more about potential microscopic spread, the goal for the D98 is at least 60 gray EQD2.
Okay, HRCTV D90 equals 8590, IRCTV D98 equals 60. Those are the targets. Now the limits, the constraint for patient safety, and these are usually measured as D2cc, right? Dose to the hottest 2 cubic centimeters.
Exactly. D2cc is the standard metric for OARs and GYN brachy. Let's start with the bladder. The absolute hard constraint for the bladder D2cc is less than 90 gray EQD2.
Okay, bladder less than 90.
But, and this is important, you need to understand the toxicity associated with that. The Embrace data is really clear here. Even pushing the bladder dose just a bit, say going from 75 gray up to 80 gray.
Yeah.
It increases the risk of having grade 2 or higher cystitis at 4 years from about 8% up to 13%.
Wow, so just 5 gray mores makes that much difference in late toxicity.
Yeah, it tells you the dose response curve is getting pretty steep in that range. Once you're hitting 75 gray, every extra gray you add starts to rapidly increase the risk of long-term problems. So while 90 is the limit, you really want to be mindful well below that.
That really reinforces the importance of good anterior backing we talked about earlier. Okay, now,
Yeah.
the rectum. This one always feels like the tightest constraint.
It is, and for good reason. The hard constraint for the rectum D2CC is much lower, less than 75 gray EQD2.
75 for rectum. Why so much lower than bladder?
It's just less forgiving. We know from the data that hitting 75 gray D2CC to the rectum carries about a 12.5% risk of developing a rectovaginal fistula.
Oof. Yeah, that's a devastating complication.
Absolutely life-altering. Which leads us to maybe the most critical planning goal distinction that every resident needs to burn into their brain.
Which is?
The difference between the hard constraint and the ideal constraint, especially for the rectum.
Okay, explain that.
So 75 gray is the absolute ceiling. You do not breach 75 grays, period. But the ideal planning goal, the target you should really be striving for based on all the Embrace outcome data, is significantly lower. You should aim for less than 65 gray EQD2.
Less than 65, so 10 grays lower than the hard limit.
Exactly. And the reason is toxicity. If you manage to keep that rectum D2CC under 65 gray, you slash the risk of any grade 2 or higher rectal toxicity, bleeding, urgency, proctitis down to the range of just 4 to 9%.
That's a massive reduction in morbidity.
Huge. So while 75 is the don't cross line, 65 is the aim for this target to give your patient the best chance of cure without severe long-term bowel problems. It's a crucial planning philosophy.
Okay, hard limit 75, ideal goal 65 for rectum. What about the other bowel structures, like sigmoid or small bowel loops that might be nearby?
For the sigmoid D2CC, and really any loops of small bowel D2CC that might be close, the hard constraint is the same as the rectum's hard limit. Less than 75 gray EQD2.
Okay, 75 for sigmoid and bowel 2. And what about vaginal toxicity? Stenosis can be a big quality of life issue.
Definitely. We track that using the rectovaginal point or sometimes a specific vaginal dose point. The goal there is generally less than 65 gray EQD2 to try and reduce the risk of significant vaginal stenosis and maintain better sexual function long term.
Less than 65 for the RV point.
Yeah.
Got it. So we have all these targets and limits, but they're cumulative, right? They add up from the external beam plus all the brachyfractions. How do we keep track?
Yeah, you absolutely cannot just look at the dose from one brachyfraction in isolation. You must track the dose cumulatively. The standard way, and really the required way, is to use a cumulative dose worksheet. The ABS, the American Brachytherapy Society, publishes a great template for this.
Okay, so you need a worksheet.
You log the EBRT dose, calculate its EQD2 contribution to each OAR, and then for each brachytherapy fraction, you calculate its EQD2 contribution and add it to the running total. Without that meticulous tracking, fraction by fraction, it's incredibly easy to accidentally blow past one of these cumulative constraints by the end of treatment.
Makes sense. You need that systematic tracking. Okay, so that leads us perfectly into the calculation itself. How do we actually do the EQD2 calculation?
Right. Understanding the formula and knowing how to apply it, it's a fundamental skill. If you can't calculate EQD2 right, all those constraints we just listed are kind of meaningless in practice, aren't they? It shows you understand the radiobiology.
Definitely. So let's get the formula straight first. Remind us again, especially for OARs.
Okay, for OARs, remember, we're always using that alpha beta of 3 reflecting late effects. The formula is EQD2 equals the total physical dose delivered by that component of treatment multiplied by, open parenthesis, the dose per fraction plus alpha beta, close parenthesis, divided by, open parenthesis, 2 plus alpha beta, close parenthesis.
Got it. Total dose X, dose per fraction plus 2 plus AC. And AC is 3 for OARs.
Exactly. Let's run through our scenario for Mrs. Jackson's rectum. Remember, she got 45 gray and 1.8 gray fractions from her external beam.
Okay, 45 fillion, 1.8 gray fractions, EBRT.
And let's assume her brachytherapy plan, for the sake of this calculation, is delivering a rectal D2cc of 4 gray per fraction, and she's getting 5 fractions.
Okay, 5 fractions of brachy, 4 gray per fraction to the rectal D2cc. We need the total cumulative EQD2.
Right. And the key is you have to calculate the EQD2 for the EBRT part and the brachytherapy part separately, and only then add the EQB2 values together. You can't just add the physical doses and convert once.
Critical point. Calculate separately, then some. Okay, start us off with the EBRT component.
Okay, step 1. EBRT EQD2. Total physical dose is 45 gray. Dose per fraction is 1.8 gray. Alpha beta is 3. So plug it in. 45 times, open parenthesis, 1.8 plus 3, close parenthesis, divided by, open parenthesis, 2 plus 3, close parenthesis.
Okay, so that's 45 times 4.8 divided by 5. Let's
Yeah,
see.
yeah.
454.8 equals 216. 216.5 equals 43.2.
Exactly. 43.2 gray EQD2. That's the dose contribution to the rectum's late effects tolerance from just the external beam phase. That's our baseline.
43.2 from EBRT. Okay, step 2, the brachytherapy contribution. She got 5 fractions at 4 grays each. So the total physical dose from brachy is 20 gray.
Correct. 20 gray total physical dose from brachy delivered in 4 gray fractions. So for the brachy EQD2 calculation, 20 times, open parenthesis 4 plus 3, close parenthesis, divided by open parenthesis 2 plus 3, close parenthesis.
All right, so that's 20 times 7 divided by 5. 27 equals 140. 145 equals 28.
28 gray EQD2 from the brachytherapy component.
28 for brachy. Okay, step 3, summation. We just add the 2 EQD2 values.
Yep. 43.2 gray EQD2 from EBOT plus 28 gray EQD2 from brachytherapy gives us a total cumulative EQD2 of 71.2 gray.
71.2 gray EQD2 total to the rectum D2CC. Okay, so clinical conclusion time. That number, 71.2, where does it stand relative to our constraints?
Well, it's below the 75 gray hard constraint. So from a strict safety standpoint, this plan is acceptable. It doesn't violate the absolute limit.
Acceptable.
But remember our ideal goal, less than 65 gray. We're quite a bit above that. So while 71.2 gray is acceptable, it tells us we're pushing the rectum fairly hard. If there were ways to optimize the plan further, maybe improve the packing, maybe adjust dwell times to get closer to 65 without sacrificing tumor coverage, that would absolutely be preferable for minimizing long-term toxicity risk.
Right, so the calculation tells us it's safe, but also maybe not optimal from a long-term quality of life perspective. It highlights why aiming for 65 is so important, and it really shows why you must calculate the components separately. If you just added 45 plus 20 equals 65 physical dose, you get the EQD2 totally wrong.
Totally wrong. The fractionation makes all the difference. Got to do it step by step.
Okay, that calculation walkthrough is super helpful. Let's try and crystallize the absolute must-know points from all this, the high-yield clinical pearls.
Yeah, the takeaways. First, the procedure itself. You absolutely need that polished cam speech. Know the sequence. MSC, dorsal lithotomy, Foley speculum sounding, ultrasound-guided tandem placement with the flange set about half a centimeter short, ovoids, and really critical meticulous packing.
And don't forget the verification. Check the CT, use the right library model in the planning system, geometry first.
Pearl number 2, applicator selection. It's driven by volume. Remember the retro embrace trial and that 30 cubic centimeter threshold? If the residual HRCTV is 30 cc's or bigger, you must add interstitial needles to get adequate lateral coverage and boost local control. It's evidence-based.
30 cc's is the line in the sand. Got it. Pearl 3.
The numbers. Internalize the critical OAR constraints in EQD2, HRCTV D90 goal, 85 to 90 gray, hard limits for OARs, bladder less than 90 gray, rectum, sigmoid, bowel, all less than 75 grays.
And crucially, that ideal rectal goal. Aim for less than 65 gray EQD2 if at all possible. That's the toxicity sweet spot.
Exactly. That 65 goal for the rectum is maybe the biggest differentiator in long-term quality of life. And the final pearl, number 4.
The radiobiology calculation.
Yep. To get the cumulative EQD2 for an OAR, you calculate the EQD2 for the EBRT part and the brachytherapy part separately, using alpha beta of 3 for the OAR, and then you sum those EQD2 results together. Separate calculation, then sum.
Perfect. Procedure, 30 cc threshold. Constraints, 90 bladder, 75 rectum bowel, ideally 65 rectum, and separate EQD2 calculation. Those seem like the absolute core points.
I think so. Master those, and you're well on your way.
All right, time for the board blitz. Let's put this knowledge to the test. Ready for the pressure.
Let's do it. Bring on the questions.
Case 1, ideal rectal constraint goal. Okay, thinking about minimizing late effects. Which cumulative EQD2 value for the rectum D2CC represents the ideal planning goal based on that embrace data we discussed? Is it A, less than 90 gray, B, less than 75 gray, C, less than 65 gray, or D, less than 55 gray?
Okay. The ideal goal. That's lower than the hard limit. It's C, less than 65 gray.
Exactly. And the rationale?
Because while 75 gray is the absolute maximum you allow, getting the dose under 65 gray significantly drops that risk of grade 2 or higher rectal toxicity down into that 4 to 9% range. It's all about reducing long-term morbidity.
Perfect. Case 2, applicator selection. All right, picture this. A patient comes in, pre-brachy MRI shows a residual HRCTV volume of 40 cubic centimeters, 40 cc's, and it has significant left parametrial extent. Which applicator approach is definitively mandated by the evidence?
A.
Tandem and ovoids alone, B, vaginal cylinder alone, C, tandem and ring, or D, a combined intracavitary interstitial applicator with needles. Okay, 40 cc's, that's clearly over the threshold. And parametrial extension, you need lateral coverage. Has to be D, the combined approach with needles. Correct, and the reasoning ties back to retro embrace. That analysis showed the 10% local control benefit for using the combined approach, adding needles whenever the HRCTV is 30 cc's or more. 40 cc's absolutely requires needles for that lateral dose shaping. Nicely done. Case 3. Bladder EQD2 calculation. Okay, get your calculator ready mentally. A patient receives 45 gray in 25 fractions of EBRT. Standard. Her brachytherapy plan is set to deliver a D2cc of 6 gray per fraction to the bladder for 5 fractions. What is the total cumulative EQD2 to her bladder D2cc? Remember, alpha beta is 3 for the bladder.
Okay, 6 gray per fraction for 5 fractions. Need to calculate this carefully. 2 steps.
Step 1, EBRT contribution. We actually did this one before for the rectum. Same EBRT schedule. 45 gray in 1.8 gray fractions.
Right, that came out to 43.2 gray EQD2 from the EBRT component. 45, 1.8 plus 3, 2 plus 3 equals 43.2.
Okay, 43.2 from EBRT. Now, step 2, the brachytherapy part. Total physical dose to bladder is 6 gray times 5 fractions, so 30 gray physical dose. Fraction size is 6 gray.
Okay, so brachy EQD2 is 30 grayless times, open parenthesis, 6 plus 3, close parenthesis, divided by, open parenthesis, 2 plus 3, close parenthesis.
So that's 30 times 9, divided by 5. 39 equals 270, 275 equals 54.
54 gray EQD2 from the brachytherapy.
Okay, 54 from brachy. Step 3, sum them up.
43.2 plus 54, that equals 97.2 gray total EQD2.
97.2 gray. So the answer is approximately 97 gray. Now, what's the clinical implication of that number?
97.2 is over the 90 gray hard constraint for the bladder. This plan is unacceptable as is. It needs to be reoptimized immediately to lower that bladder dose. Better anterior packing, maybe change dwell times. Something has to give.
Exactly. That calculation shows a violation.
Yeah.
Excellent walkthrough. Last one, case 4. Target goal, HRCTV D90. Back to the tumor target. Based on Embrace guidelines, what is the primary dose goal we're aiming for the high-risk CTV D90 expressed in EQD2? A, 60 gray, B, 75 gray, C, 85 to 90 gray, or D, 100 gray?
The main tumor target goal, HRCTV D90, that's got to be high for cure. It's C, 85 to 90 gray EQD2.
Correct again. Why is that the goal?
That's the dose level demonstrated to be necessary to achieve high rates of local tumor control in definitive cervical cancer treatment. It's what drives the whole brachytherapy planning process, hitting that target while respecting the OAR limits.
Fantastic. You nailed the board blitz. Okay, let's quickly summarize the absolute key takeaways from today's session.
Sounds good. So we covered a lot, but I think it boils down to a few core things. First, that systematic procedure, know your steps, the canned speech, the checks, the ultrasound guidance, the packing. Safety and precision are paramount.
Right. Second, that crucial 30 cc threshold from retro embrace. It's your evidence-based trigger for adding interstitial needles to handle larger or more lateral tumors and maximize local control. Don't guess. Use the volume criteria.
Third, master those constraints. Know the hard limits, bladder 90, rectum bowel 75, but really internalize that ideal rectal goal of aiming for less than 65 gray EQD2. That's where you make a huge difference in minimizing long-term toxicity.
Couldn't agree more. And finally, the math matters. You have to calculate cumulative EQD2 accurately. Remember to do the EBRT and brachytherapy components separately, use alpha beta of 3 for OARs, and then sum the EQD2 values. Track it meticulously.
Yeah, that accurate calculation is the only way to truly know if your plan is safe and meeting those critical constraints.
You know, modern cervical cancer brachytherapy. It's such a powerful tool, maybe the best example of dose escalation we have in radiation oncology, but it absolutely demands this really deep integrated understanding of the technique, the patient's specific anatomy and tumor volume, and the underlying radiobiology.
Absolutely. When it's done well, with this kind of meticulous attention to detail, it saves lives and preserves quality of life. But you have to respect the complexity and the potential for harm if you cut corners.
Well said.
If you want to practice these concepts further, maybe try some practice oral board scenarios based on this, you can check out radoncsmartlearn.com.
Definitely do that. And be sure to subscribe to Rad-On Smart Review for our next session. We'll be shifting focus a bit, looking at some of the newer standards in cervical cancer management, things like integrating immunotherapy and how we approach recurrent disease. Should be interesting. Thanks for tuning in.